Good morning, everybody. I think you might be surprised to see someone other than the Chief Resident do the introductions, but today is a special day. It's the annual Boone Vance Memorial Lecture Day, and I'm Norman Moore. I'm the chair of the Grand Rounds Committee, and so I thought we'd make a few changes in our usual introduction. And the first thing I want to do is welcome Dr. Mary Miller to come and explain to you all a little bit about Boone Vance. Dr. Miller was a long-serving chair of our department until recently, and she knows a lot about the history of the department and particularly of Boone Vance. So I invite Dr. Miller to come and have a word.
So we established the Boone Vance Memorial Grand Rounds Fund a number of years ago after Boone Vance unexpectedly died. He was a member of our department starting in 1992 until he died in 2003, very unexpectedly. He was a psychologist. He had a PhD in educational psychology, and he was an extremely humble man. He was from Carter County and loved to tell people about how if he could do it, anybody could do it. I remember him giving a grand rounds right here one day on how to publish. He was very well published, very successful, and he gave us all tips on how there's so many journals, and if you just put your mind to it, you can really do a lot. He had wide-ranging interests. He was interested in ADD, in dementia. He was a consultant for a nursing home and put some really creative ideas in place there. And he was interested in learning disabilities. He had a learning disability himself, but was able to overcome it and get his PhD. He was a really warm and friendly person, and every time he saw me or anyone else, he would always say, "Is there anything I can do for you?" So I just want to tell you, each of you got a little flyer that tells more in more detail about Boone, and we established this fund originally to remember Boone, but at this point in time, so many years have gone by. I know most of the people in the room never knew Boone, but this is now our one and only fund to help us bring in outside speakers without having to do it the old-fashioned way of getting drug company money. So if anybody is willing to support our Grand Rounds program, that'd be very much appreciated. So I'll turn it back to Dr. Moore, who's going to introduce our speaker for today.
Thank you, Dr. Miller. So it's my pleasure to introduce our guest lecturer, Dr. Deborah Kim. She's a perinatal psychiatrist at the Perelman School of Medicine at the University of Pennsylvania. She's an assistant professor and chief of the perinatal division of the Penn Center for Women Behavioral Wellness. Since 2005, Kim has been studying the use of transcranial magnetic stimulation in pregnant women with depression. In addition, she studies the fluctuation of neurotrophins during pregnancy and the effect of early life maternal trauma on the HPA axis and its regulation of the mother during pregnancy. She has funding from the National Institute of Mental Health to support her research. In addition, Dr. Kim works clinically with pregnant and postpartum women and also specializes in treating medically ill women who have psychiatric illness. She's a dual boarded in both psychiatry and psychosomatic medicine. Dr. Kim has published many peer-reviewed articles in the field of perinatal psychiatry, is an active speaker and teacher, and has won several teaching awards at her institution. She's an energetic mentor and advocate for women in medicine and a member of the Penn IRB. So I myself do TMS, and I'm soon going to be doing some studies which will include TMS on pregnant women, and I wanted to learn more, and I found out that there was a lecture being given at an annual meeting of a society called the Clinical TMS Society. I went there and I heard Dr. Kim give the lecture, and I was very impressed by it. I was also impressed by her friendliness and supportive attitude when I went to speak to her, and I was delighted when she accepted our invitation to come down and give us the annual Boone Vance Memorial Lecture. So I just want to introduce her and leave it to her.
Thank you so much. Ooh. Do this so it won't be too annoying, and I will try to speak up with them. Okay, can you hear me okay? Well, thanks for having me. Unfortunately, I'm over here overnight, but I am definitely coming back because this is a great city. So I'm actually a perinatal psychiatrist, and I'm going to talk to you some about antenatal depression and the use of medications during pregnancy as a way to segue into TMS during pregnancy, but also as a way to kind of generalize the interest to people that may not be so interested in neuromodulation. And I am a perinatal psychiatrist. Neuromodulation is not my specialty, but when I was a fellow, John O'Riordan was starting to study TMS, and he was the lead author on the FDA, the study that led to the FDA approval of TMS. And because I was interested in treating pregnant women, the idea of using something that did not need medications became very interesting to me. And so I started to think about that. Besides my funding from NIMH, I am Neuronetics, which is in Malvern, Pennsylvania, lends me, they've now given it to me because it's so old, they don't want it back, their TMS device. They have not been involved with study design or anything like that. So we're going to talk about antenatal depression. So why am I doing this? Why TMS? What is the state of the data? And what else needs to be done in this area? So depression itself is self-limited. So is pregnancy. There's been a lot of controversy about whether antenatal depression or depression during pregnancy actually exists or not. When we look at the meta-analysis, this was a meta-analysis done of multiple studies, we can see that you can see a pretty people don't feel well, women don't feel well. If they have a lot of nausea, they can look very sick. They can even look personality disorder during the first trimester. And so unless somebody has a lot of hopelessness, guilt, and things like that, I tend to try to wait out the first trimester and look at the second and third trimester. Now, that doesn't mean that you cannot diagnose it. I just think it's more difficult to diagnose in the first trimester. But by the second trimester, women are usually feeling generally pretty well. And so if there's a lot of hopelessness, helplessness, sadness, you really want to take that into consideration. Now, this is a study that probably most of you have seen, but I just think it's an important one out of Harvard just to remind you of. It's older now, but again, important. And this is where they looked at 201 women, and this was a naturalistic study, so they just followed the women over time. And the women with their doctors decided whether they were going to stay on their antidepressants or not stay on their antidepressants. And they found that 43% of women relapsed with their depression during pregnancy. Women who maintained their medications had a 26% relapse, and if you discontinued your medication, you had a 68% relapse. The important thing to understand about this study is who was the population. So the population of this study were women with moderate to severe episodes of depression. Most of them had about an average of 4 lifetime depressions. And we know just from other data outside of pregnancy that if you've had 3 or more depressive episodes of moderate to severe depression and you discontinue your medication, your relapse rate is about 70%. And you can look at this in all forms of illness during pregnancy, so it's not rocket science. If you can take a past psychiatric history, you can predict pretty well for somebody their chances of relapsing during pregnancy. It's actually their chances outside of pregnancy. So it's not that somebody cannot develop a first episode of OCD during pregnancy. That can happen. But most commonly what happens is pregnancy is not protective. It's not a time of increased risk. But it just, whatever would have happened to you outside of pregnancy will happen to you inside pregnancy. Relapse is more common in women with more previous episodes, longer length of illness, and an episode in 6 months prior to conception. So a lot of times women will come to me and say, well, my doctor said I had to be well for 2 years prior to conceiving. That's not data-driven. That's somebody that does not want to treat you during pregnancy. And so, again, the data really shows that you're less likely to relapse if you're well in the 6 months prior to conception. Does anyone have any thoughts about why? So this is a study from 2006, and a lot of people like to point out that the relapse rate in women that continued their medication was 26%. Does anyone have any thoughts about, knowing that this is an older study, why that might be? Because there's been some data that has come out of Pittsburgh over the last 5 or 6 years that shows that just like lithium and Lamictal, women metabolize the antidepressants more quickly as the pregnancy proceeds. So this study was done before we knew that. We don't know this for sure, but it's very likely people were not increasing their medications during pregnancy. And we now know that around 28 to 32 weeks of pregnancy, the P450 enzymes really kick up, as well as you have increased GFR and other kinds of things, increased fat distribution, other things going on. And your blood levels really decrease significantly. And so we do know that in some women, we don't know exactly how many. In my practice, it's about 20% of women. You do need to increase the dose as the pregnancy proceeds, which again can be controversial. We could talk about that if anybody has any questions. So who cares? Again, the pregnancy is going to end. Does this really matter? There are both mother and child risks to being depressed and pregnant. So there's an increased risk of preterm birth, increased risk of low birth weight, increased risk of intrauterine growth retardation. We don't know whether this is an effect of the biological effects of depression, epigenetic effects, or whether this is related to poor health behaviors. There's increased risk of developing postpartum depression and suicidality. Postpartum, so the one thing that pregnancy is protective for is suicidal acts. Pregnant women are just as likely to report suicidal ideation during pregnancy as they are outside of pregnancy. The 12-month prevalence is the same, it's 2.6%. But they are less likely to act on their suicidal acts. So I don't care how borderline you think that patient is. If she comes into your ER during pregnancy, she should be hospitalized. That is really unusual and a really bad sign. And again, they are more likely to engage in high-risk health behavior. And this is what's confusing about looking at the medication data. So antidepressants are actually the best studied medications in pregnancy. What makes the data so confusing is the lack of randomized controlled trials. The other issue is if you look at these studies, and studies that look at the number of women that smoke, use drugs, and drink alcohol, and don't go to their prenatal visits, and don't take their prenatal vitamins, it's far increased if you have a mental health disorder. So for example, most of these studies will show that women will drink at 8 times the rate of women that do not have mental illness. And we all, I think, can agree that there's no safe lower limit of alcohol during pregnancy. So a lot of what's going on with these drug studies or these antidepressant studies is we don't completely know what's the depression, what's the medication, what's the poor health behavior, and it really makes the data difficult to interpret. And so when you talk to people that do this work, and this is all they do, they'll tell you the medications are low risk, and that's because in our practices we're trying to control for all of these things, and so the medications actually come out looking pretty low risk. So again, it's just not clear exactly what is going on. This was a study that we did at Penn, and all we did was, at the first time you came for your OB appointment, a third was that was their first trimester, a third second trimester, a third their third trimester. I work in the inner city. And we looked at if your Edinburgh Postnatal Depression Scale, which is a common scale used to assess depression both during pregnancy and postpartum. If it was above 10, what was your risk of developing preeclampsia, low birth weight, preterm birth, IUGR? And we controlled for all kinds of stuff because we had the medical records. And again, the biggest risk for preeclampsia is preeclampsia. So even when we controlled for all of those things, we still found quite significant increased risks based on your Edinburgh Postnatal Depression Scale. And what's very interesting about this is that the national rate of preterm birth is somewhere between 11 and 12%, but at Penn it's actually 6%, even in our low SES clinic, in our Medicaid clinic. And that's what this group was. And so we were still seeing, even though we knew we were doing a pretty good job with these women, that if they were depressed, that the birth outcomes just weren't as good. This is a recent study from the Avon Longitudinal Study, which is a UK study where they followed 4,500 folks over a number of years. And I found this study very interesting. The reason this study is interesting is they looked at whether mom had depression during pregnancy and whether her 18-year-old offspring had depression. And they controlled for all postnatal depression. And they found an increased risk of that 18-year-old having depression if she had depression during pregnancy. The other thing they did is looked if dad had depression during that time. And his level of depression, while postnatally mattered, his level of depression during her pregnancy did not matter, suggesting, again, some biological, some epigenetic effects going on, that there's something in utero going on with her abnormal HPA axis function that's being transmitted somehow to the child. Now, we're studying how that might be working. We don't know how that happens, but we're studying how that is working. But I think, again, it lays the groundwork for saying that being depressed or anxious or whatever during pregnancy may not be a normal in utero state, right? That's the first environment that the child sees is the uterus. And maybe that, if that is a depressed uterus, that is not the optimal state. There were consensus guidelines published for the treatment of depression during pregnancy in 2009, published both in the psychiatric and OB literature. These are consensus guidelines, so it means a bunch of people who are experts in the field got together and decided what they thought was best. And they recommended psychotherapy for mild to moderate depression. The best therapies during pregnancy are cognitive behavioral therapy and interpersonal therapy. There's older literature on psychodynamic and psychoanalysis, but that literature is a little more difficult to interpret just because of the ways that the therapies are delivered. And they recommended antidepressants plus psychotherapy for moderate to severe depression. Now, again, the data was not from prospective RCTs, but this was the first time really anybody came out and said, look, it's okay to do it. We think the risk is low enough and the benefit is high enough, and it's probably okay to do it. So what are the risks of antidepressants during pregnancy? There are three main things to think about. So the risk in the first, it's best to think about it by trimester. The risk in the first trimester is really of congenital heart malformations, cardiac malformations. Every single antidepressant has a study published that shows there's an association between that antidepressant and a cardiac malformation, mostly VSDs and ASDs. But none of the data in the very large database studies really support that. In 2008, JAMA published two back-to-back studies in August 2008 where they had two huge databases and there were completely different studies. They were completely different results. And so I just think it's very confusing to know how to counsel people because, it's a high-risk thing to do. Women who are pregnant, they certainly don't want anything to go wrong with their pregnancy, and so it can be scary and confusing to try to counsel women about this. The risk of cardiac malformation occurring in a woman with an antidepressant, whether it's causative or not, we could argue at length. Most people think it's not causative, but whether it's causative or not is about 1%. So the absolute risk is still very low, okay? So that is above the risk in all pregnancies, but so the relative risk is increased, but the absolute risk is very low. Otherwise, there's really been no consistent studies showing that there's a consistent association between antidepressants, and I mean all antidepressants, not just SSRIs, antidepressants and congenital malformations. Clomipramine may have a little bit more risk in terms of cardiac malformations, but again, all the data doesn't support that. But other than that, they look to be pretty low risk. In the second trimester, you worry about growth. That data has been very inconsistent, and it appears that antidepressants do not inhibit growth, at least during pregnancy. So if you give venlafaxine for migraines to children, there's been some data that it might inhibit growth, but again, during pregnancy, we've not seen anything consistent that looks like that. So the risks, weirdly, are mainly third trimester, which is sort of the opposite of what we generally think about when we give medications during pregnancy. The biggest risk of what we call poor neonatal adaptation syndrome. We call it that because we don't know whether it's withdrawal or whether it is toxicity of the medication. It occurs in about 10 to 30% of infants, resolves by day 5. So the protocol is actually to monitor for 48 to 72 hours. We do allow our women to deliver in birth centers. They don't have to deliver in the hospital. And the first, it's not fully a study, but the first case series just came out this year showing that women that nursed on Remeron, mirtazapine, had a decreased rate of PNAS compared to women that were exposed during pregnancy but did not nurse. So that's a question a lot of people ask. Well, what if I nurse? Will that decrease the risk of withdrawal? It's a great question, but we don't know. Is there drug in colostrum before your milk comes in? We didn't know the answer to that. And so that is the very first set of data to suggest that maybe nursing will decrease the risk. I've only ever seen this a couple of times. I saw it once in someone who was on venlafaxine 450 milligrams. The kid is 7 now, doing fine. I saw it once in twins exposed to 80 milligrams of Prozac along with a bunch of other medications. They are also doing fine. The tremors stopped by day 2 or 3, and actually the more the mom held them, the less they tremored. And so, again, the infants are doing fine. So it's really not so common. The people that seem to be bothered most by it when I talk about it are people who've experienced antidepressant withdrawal themselves, or people that have abused substances and have gone through withdrawal. And when they bring that up, I say to them, I think that's a great maternal instinct. I mean, I think it's great that you're worried about your newborn experiencing something negative. But let's look at the bigger picture and try to figure out together what really the best answer is. You can decrease the rate of it if you taper in the 3rd trimester, but the problem is then you increase the risk of postpartum depression. So you really have to weigh that. I don't taper, but nobody's going to fault you for tapering. But again, postpartum depression is very dangerous and really can lead to some child abuse, suicide, things like that. There was a meta-analysis showing a higher risk of respiratory distress in exposed neonates compared to exposed. Again, we put that under PNAS, the biggest thing that we worry about. So if somebody's delivering at a birth center, we just want to make sure they have respiratory support before they can get the kid to the hospital, and never lost anyone. Because again, it tends to be fairly mild and resolve fairly quickly. There is a risk of preterm birth. The data is conflicting, but the studies show that there's an increase from the baseline, which I said was 12% to about 20%. If you're exposed to an antidepressant, you'll be born 5 days earlier on average as if you weren't exposed to an antidepressant. Now, if you talk to an OB, they'll say, well, 5 days is really significant. I mean, if you have the difference between birth at 22 weeks and 23 weeks and 24 weeks in morbidity and mortality is huge. But that's not what we're seeing. We're seeing late preterm births versus non-preterm births. So these are babies that are born at 36 weeks and change. And what it's doing is pushing some kids from 38 to 37 weeks a little bit earlier. So it's not causing very early preterm births. And there's, again, a big push at Penn to make it to 39 weeks. And so, again, I don't want to underestimate that risk, but I want us also to put it in perspective. And then the other thing that I said is that if you're depressed, you also have an increased risk of preterm birth. And the biggest risk factor, the thing that will wipe all of this out, is if you have a history of preterm birth. So if you have a history of preterm birth, that is by far the biggest risk factor. So it's really important when you're talking to these women to get that history, because you don't want to assume it's the antidepressant if that's not what's going on. What are some of the controversial risks of antidepressant? PPHN. I don't want to spend too much time on this, but I'm willing, certainly to talk about it afterwards. The first study came out in 2006. In December 2011, the FDA pulled back or made a revision of their warning. We no longer think that there's an association between PPHN and SSRIs. The original reason it caught on so well is because the mechanism made sense to those of us that didn't know anything about it, really what was going on. And then when the embryologists got involved, they actually said the mechanism didn't make any sense, and I think it kind of lost some steam at that point. But there are still studies out there which show an increased risk. But again, the absolute risk is less than 1%. So if there is an association, it would be very unusual to have isolated PPHN as a result of an antidepressant. PPHN is associated with lots of other things: obesity, meconium inhalation. It's associated with a lot of things, and I've never seen it in isolation in relation to an antidepressant. Autism has been catching on, at least in the Northeast. The New York Times has been publishing studies comparing taking your antidepressant during pregnancy to eating brie. during your pregnancy. And the reason that they made that association was because of this potential risk of autism. Most of the perinatal psychiatrists that I talk to and go to meetings with, some of the data is that the association is really very limited. One of the studies, despite the name of the study, if you read the study to the end, they actually say that they think the antidepressants only contribute about 3% of the risk of autism. In my practice, the rate of autism is 1%. That is the rate of autism in the population. And I don't have anybody actually that was only exposed to an antidepressant that developed autism. All the kids that developed autism were exposed to multiple medications or were the children of women with bipolar disorder. So again, if you give animals, the reason that this again became important was that if you give animals high doses of SSRIs, they absolutely have social behaviors that look autistic as much as an animal, I guess, a rat or a mouse can look autistic. And so, again, it was important to study, it made sense, but the placenta is the most species-specific organ. So giving a rat or a mouse medication is not the same as giving a human woman medication because the placenta is basically the baby's liver. So you take the medication, gets to your gut, your liver breaks it up, then it gets into your bloodstream, then they all get across the placenta because the same molecular qualities that allow you to take a medication in your gut for it to cross the blood-brain barrier, same reasons that it can cross the placenta and get into breast milk. So all psychotropics cross the placenta, all psychotropics get into breast milk. But by the time they get to the placenta, then the placenta has something called placental glycoproteins, and the job of those are to knock out things that it doesn't recognize, and cortisol gets broken down, and all those kinds of things. So the placenta really works very hard not to allow things that it doesn't recognize across. There are 3 placental models that have been examined in terms of antidepressants that we just have looked at and just wrote about. None of them are very good, unfortunately. So we don't really understand completely very well how much of each antidepressant gets across and which would be better and all that kind of stuff. And remember, the placenta is half fetal genetics and half maternal genetics. So it's really complicated. You can't just take a rat study or a mouse study and assume that that's equivalent to a human study in perinatal psychiatry. And that's part of what has made this so confusing. So we really have to study it in humans, but that is difficult. And that's where people like myself come in because we love to do things that everyone says you can't do. When we look at antidepressant acceptability, people will talk about decisional conflict. So women have high decisional conflict about taking medication, specifically antidepressants during pregnancy. And when we looked at this in relation to TMS, we also found that people much preferred therapy. There's study after study after study that shows that pregnant women will prefer psychotherapy much before they prefer medications. Being more depressed, older, and Caucasian are all factors that increase acceptability of medication during pregnancy. And again, that's been replicated multiple times. So my sort of stance was, okay, so they work and they're probably low risk, but people don't want to take them. So, can we offer them something else? And that's where this idea of transcranial magnetic stimulation came in. And the first case was reported at MUSC. This is Mark George's group. Dr. Nahas is no longer there, but they reported this group this study, and what this was they had a very early TMS study, and they just didn't make pregnancy an exclusion criteria, and the IRB didn't notice. So this IBM executive came along and said she wanted to be in the study, and they said, well, you're pregnant, you can't. And she said, but there isn't any reason I can't be in the study. I don't meet the exclusion criteria, so they actually decided to allow her in the study, and they published this first case report. And that's all there was for almost 10 years. And then came a few more case reports. So we had 2 cases reported, one with high frequency, one with low frequency TMS. I'll talk more about that in a second. And then we had another one in 2009 where they published 3 cases, but there was very little data about what they did. So based on a total of, how many is that? So based on a total of 6 cases, we decided to do a pilot study. And this was an open label study. It was an actual study, but it was open label. And we gave 10 women right-sided low-frequency TMS during pregnancy. Now, I started this in 2005, so the reason that we did right-sided was simply because at that time we thought left-sided TMS caused seizures more commonly than right-sided, and the data was starting to come out that right-sided looked as good as left-sided. Now, I will still argue with you that right-sided is as good as left-sided, but that's an argument that can go on forever. But really, it doesn't matter. The only reason we did it was because of the risk of seizure. You don't want somebody who's pregnant seizing, because that can cause fetal death. So that's what we did. We didn't include first trimester women because we knew we were doing something unique, and we didn't think that there was any risk during the first trimester, but we didn't want to accidentally shoot ourselves in the foot and have a bad outcome that would be associated with the study. And so we really did everything we could to pick the healthiest women possible. We did antenatal monitoring. So my original study we actually did in a unit that was right off the labor and delivery floor. We did a ton of antenatal monitoring. We had the OB stand there for the whole first visit. But what we actually found was that it was the growth ultrasounds before the treatment that ruled out the people that really shouldn't be in the study. We didn't find anything abnormal with all the antenatal monitoring that we did, but we did a lot of it just to make sure that we weren't doing anything unsafe, because the physics of the magnet is that it gets about 2 by 2 centimeters into the brain. So there wasn't a question of whether, so the Rossi guidelines that were published in 2008 say pregnant women should stay a certain amount of whatever span away from the magnet, but that's really, again, not really based on anything that makes sense in terms of the physics of it. So we weren't really worried about the magnet being exposed to the uterus. What we were worried about was whether we were going to cause systemic changes that would somehow alter the pregnancy. When I say we, I mean the FDA was worried about that. We actually weren't worried about that because at Penn, those studies actually had already been done, and we knew that the hormones, thyroid, all that kind of stuff did not change, but that's what they were concerned about. So these were the women that we had. They were anxious. They were sick. So people that come to us for TMS are not, even though our entrance criteria were really for mild depression, people that come to us are people that are quite ill. And in this open label study, it looked great. People got better, but it's an open label study. So really what this was a safety and feasibility study. And so people got better, as you would expect. Oh, well, the other thing is they got better with their depression, but not their anxiety. That does not mimic all TMS studies, but we have tried very hard to make sure that people don't have the primary diagnosis is not anxiety, because really they just don't do as well. So we did see a change in depression and not anxiety scores. But really we were interested in safety, no serious maternal adverse events, headache, which is common anyway. We started to discover that we were getting what's called supine or postural hypotension. This was the first time this happened, so that means when somebody's a pregnant woman of a certain gestational age is lying on her back, she gets lightheaded because she's putting pressure on her inferior vena cava. So that was the first time we experienced that. The antenatal monitoring was normal. And then one participant had a uterine contraction at minute 18 after her last treatment. And we made her stay there for another couple hours just to make sure everything was okay. And the kid is 6 now, I think. We did the ultrasounds. Again, no change, but we still continue to do the ultrasounds pre and post. Not because we're expecting to see a change, but really it's a very good screening tool. So if somebody already has growth restriction, it was how we picked up drug use. We picked up all kinds of stuff by just doing the ultrasound. In this study, all infants were born greater than 37 weeks gestation. That's pure luck. We should have had at least one, but it was just luck that we didn't. And all the infants did great. 4 males, 6 females. They were born 39 weeks. They were big. APGARs were good, no congenital malformations and no NICU admissions. And again, I didn't point this out, but some of these women actually were on antidepressants. So you would have expected, just based on that alone, that we might have had a NICU admission, but we did not. Then the first high-frequency pilot study came out, and this was a study where they looked at 30 pregnant women. They did a 25 hertz session, 1,000 pulses at 100% motor threshold, so that's high frequency. And they did 3 weeks of 6 days per week session. So if you think of a pulse is a dose, you want to know how many pulses somebody's getting, and that basically tells you the dose of TMS that somebody's getting. Left is high frequency, right is low frequency. It's a little bit more complicated, well, a lot more complicated than that, but it's just sort of an easy way to think about it. They had a 41% reduction in Hamilton, 30% had a partial response, only 1 person got worse, and 21% achieved remission. They since looked at the children of, and published about the children of this study, and they found that the children were the same as a control group, except that the mothers of the children who were treated with TMS, or the mothers that were treated with TMS who had children, even though the children were the same, the mothers had perceived language delay actually in their children, despite that the children actually didn't have any objective language delay. So that is something very common actually in perinatal psychiatry, that women will perceive their children as more irritable, more difficult, and you'll see that quite commonly actually. So we embarked on the first randomized control trial of a biologic treatment in pregnancy, and we did this with TMS. We have a sham coil. It's a similar study design, except we decided not to do as much fetal monitoring, and we increased the number of pulses per session from 300 to 900. So we tripled the dose basically, but that's still half of the FDA approved dose for right-sided TMS. We kept the motor threshold at 100%. The reason that we did this, which won't mean anything to anybody that doesn't do TMS, but the reason that we did that is because you have to turn the power output way up during pregnancy, and I couldn't get to 110, 120% anyway, so we just kept it at 100%. So basically you come in, you get your vital signs, you sit there for 15 minutes, and then you leave and you go to work or you go do whatever you want to do. So it's great, and this study has been done over 5 years. We're finishing it this December. What we're actually doing right now, we've actually finished the taking people in for the clinical trial, and what we're doing now is we've just completed the first functional MRI in a pregnant woman for research at Penn, because we're actually, based on some conversations with Mark George down at MUSC, looking at resting state pre and post TMS in pregnancy. So it turns out at Wayne State, they're MRIing fetuses, and people are doing all kinds of stuff, and you can do resting state very quickly. And I didn't know a lot about fMRI, but when I found out that, and that there are special coils that you can use, it took me 6 months, but I convinced the IRB that it would be okay. And I think we, as perinatal psychiatrists, thought women wouldn't agree, and they're agreeing. They're fine with it. So in this study, we've only had 1 subject on concomitant antidepressants. This just coincides with lots more data coming out about the antidepressants and people not wanting to take them. And they're just 2 different groups. In my clinical practice, people come to talk about antidepressants. And this is just a different group. They seek us out. They're often being treated at birth centers or things like that, and they really just don't want to be on their antidepressants. We look at brain-derived neurotrophic factor pre and post-treatment. There is data which shows it changes with TMS. That has not been seen in my data, but that's probably a result of multiple factors. And we also look at cognition pre and post. We've become very interested in cognition in pregnancy. 43% of pregnant women get into a car accident while they're pregnant. You always talk about pregnancy brain, and is it real, is it not? And there was data that just came out that showed it wasn't. But I don't know. People complain about it. And you know, when I saw that motor vehicle accident data, I got interested in that. So we're doing some more study about cognition during pregnancy, trying to understand if there really is an issue or if it's more a subjective thing as opposed to objective thing. So this is just the demographics of our women. I don't think there's anything super interesting or important here. These are our preliminary results. I don't have the last 2 sham people in here yet. But we're just about to write up the paper. So, but the important things is that in the first study we didn't look at estradiol or progesterone over time. it seemed to me unimportant because you can't maintain a pregnancy unless your estrogen or progesterone are certain levels, but the FDA insisted we looked at it, so we looked at it, and we didn't find anything different based on whether you were getting the active or the sham coil. And what we found was a really high placebo rate. So I was just talking about this earlier, that we made a huge effort to not chat with the patients, to really standardize how we were interacting with the patients, and we have a really high placebo rate. And so even though our active folks have done better than our sham folks, and I don't know what it'll look like when we add the last 2 sham people in, the problem with the study is that we have a really high placebo rate. There's been a bunch of questions about whether maybe we have an active placebo, because our placebo actually uses a TENS machine, so that not only do you have the sound, but you have the facial twitching. I don't think that's what's going on, because the placebo responders respond after day 1 of treatment. I mean, they respond like placebo responders, and the amount of electricity that they're getting is incredibly low. I'd find it really hard to believe, but some people have questioned that. So 22 women completed at least 10 treatments, 20 completed all 20. One of the things that we found, even though people come in every day, is that once we get them in the door, they stay. There's something about the structure of coming every day that is really important to these women. And even though we try not to chat with them, we obviously care about them, and that seems to make a very big difference to them. So 75% of the subjects receiving active responded, and 50% received placebo responded. So it looks like it's better, but our numbers are too low to know. And then you can look again at the remission. And so response was 50% decrease in your Hamilton. Excuse me, remission was defined as a Hamilton score less than 8, and a CGI, a global, a clinical global impression scale of 1. One woman was lost to follow-up prior to delivery. Of the remaining 21, actually everybody's delivered now. So all 21 have delivered, and all the infants were healthy. We did have one that was in the NICU for serum glucose reasons, which we believe were unrelated to TMS. And so far, we haven't seen a significant association between the BDNF. This doesn't seem to be the right biological target, which is why we're looking at fMRI. And the kids look good. So even though we're seeing things happening, we're not really seeing difference between the active and the sham groups. These are our adverse events. Again, these are adverse events that you expect with TMS anyway. There are things that you can do about some of this stuff. If you're getting the facial nerve, ways you can move the coil. But the only thing that we saw, which was related to pregnancy, was something called, we talked about this, postural supine hypotension. And so just because of the way our chair is, what we do is do a 30-degree pelvic tilt after 24 weeks of gestation, just like you would do with ECT. And since we've been doing that, we've not had anybody have this, and we did publish this data. So I'm just going to stop with this. There's all kinds of questions about, kind of where do you go from here? What really is the biological target? Should we be increasing dosing? Would you take, so if I could, do this again, I would do an acute phase, then I would do a taper and maintenance phase. There would be all kinds of ways to improve our outcomes. I know that there is somebody out in California who uses my studies to recruit patients for TMS during pregnancy. My personal opinion is that the state of the data is still very early, and I don't really think that based on 2 studies and a few case reports that you should really be telling people that TMS is absolutely safe. That to me is not really the way that this should go. But what I will say is I do think we're moving in a direction where we're looking for special populations in which we can use TMS. And I think this is one of those special populations, and it may be because it is so easy to deliver that you could actually have these in the OB office. And you could be treating women, really in a different environment. So I wanted to leave time for questions. Oh, I did it, 45 minutes.
So we have time for some questions. Dr. Kim has to get to the airport in time for a flight, so we're a little bit pressured. We want to allow her to get a lunch and then get on the limo and go. So we'll maybe limit questions to about 5 or 10 minutes. There's Dr. Miller.
Yes. Yes, with Prozac, yeah. I did. I did. So my I don't want rebuttal or to that is that we only look at well, we're not anymore, but we only look at what's wrong. And now studies are coming out showing actually that there may be some improvement in kids that are exposed to antidepressants. So there's a group that studies choline supplementation in women with schizophrenia during pregnancy, thinking that that might decrease the risk of schizophrenia in their offspring. Their control group actually was a group of women, depressed women on antidepressants. And they actually found, and then they had a separate control group, and they actually found improved gating in the brain in the kids that were exposed to antidepressants. And that came out in the American Journal of Psychiatry, I think in February 2012. I happen to know that because I keep it in my office. This was the very first study I ever saw. And I think part of the issue, and there's been a couple more studies, but I think part of the issue is we're just looking for what's wrong. So what if there's 1% rate of negative outcomes, and then there's like a 50% rate of these kids actually do better? You know what I'm saying? So I understand what you're saying, and I think that being conservative is not a negative thing, but the way that I start my thinking is that depression is a toxin. So I'm not bringing Mrs. Smith off the street who's completely healthy and giving her Prozac. I mean, that's not what's happening. What's happening is she has an illness that's neither her fault nor my fault, and she's decided she wants a biological pregnancy. So the other thing you have to remember to talk to people about is all their reproductive options. So there's a great article actually in the Journal of American Psychiatry where they did a case report on a woman with bipolar disorder and how she went on to do surrogacy for her second pregnancy. And I think you have to remember that somebody's coming to you because they've decided A, they want to have a biological pregnancy, and B, they have this illness. And so, you know, I have a mentor that that has always said to me, people are better with us being involved than with us not being involved. And so I just think, I used to put up this slide, but I don't put it up anymore. Women come into my office really frightened about what I'm going to tell them. And my number one response is people will be crying, and I'll ask them while they're crying, and they say they just feel so relieved. They feel so guilty. Do I deserve to be a mother? Do I have the right to want to be well during pregnancy? You know, it's so complicated. And so I think these studies are very complicated. So what happened, that study came out, and I have a very close colleague. She's actually a perinatal psychiatrist, had her first kid on Prozac, thinking about her second kid, and the first thing I get is this text. I haven't even seen the article yet. Did you see this? So again, you have to take it in context. You know, who was drinking during that study? Who was smoking during that study? Again, what were the health behaviors? And I think the absolute risk is very small. And being pregnant in itself has a 3% risk that something's going to go really badly. So, you know, again, I think you have to take the bigger picture. And I mean, this gets a little bit into my political beliefs, but I don't believe that just because you're pregnant, you can't give informed consent. So I give them all the information, and I do make a recommendation because they pay me a lot of money, so I'm not going to just vomit data at them and say good luck with that. I do make a recommendation based on what we've talked about. And most of my anxious patients will actually choose to try to come off their medication or switch to sertraline. It's very interesting. The depressed patients don't care. They'll do whatever. But they always, 9 times out of 10, they end up on the original medication they were on or back on their medication. But they feel good because they know now that they quote unquote need it. But 10 months is a really long time to struggle. And then the other issue that comes into play is, what if there are other little people running around? So what if this is your second or third child? And we know that in child development, years 0 to 4, some people will say 0 to 5 are incredibly important. If you are living with a depressed mother or an anxious mother for 10 months, that can have long-term effects on your development. So I actually counsel a little differently in second and third and fourth pregnancies than I do in first pregnancies, because you've got more people to think about. We also know that the partners are less likely to do well if she's not doing well. So I think it's really complicated. And I am not conservative in my use of medications during pregnancy over the last 15 years that I've been doing this. And I have not really seen them, we just don't really see negative outcomes. And my favorite is when it's, not my favorite because it's psychologically very difficult for the woman, but, she'll have kid 1 or 2 off medications, she'll have a bad postpartum depression, and then she can't come off her medication, so kid 2 or 3 will be on, and then she'll call that baby her Zoloft baby. And she'll say, oh, this baby is just so easy compared to my other kids. And it's not Zoloft. That's because when you're not depressed, you interact and you view your world differently. And there's lots of qualitative studies that show this. And so, the baby doesn't look any different to me than all the other babies that I see. But really what you're doing is you're creating a situation where the mother can interact well with the baby. So we know that women who have postpartum depression, whether they've been exposed, the kids have been exposed to medications or not, actually doesn't matter. The kids who are exposed to the depression will have a lower verbal IQ. And actually whether they've been exposed to medications in utero or not doesn't happen. So that's the hard sell for, I think the depression is worse than the medication exposure. That being said, I believe that you should have a range of options. And if we can avoid medication exposure, sure. Therapy, great. Absolutely. There are women I turn away from my study because they're clearly it's clearly a situation and they need to go get therapy. If we can do TMS, great. But in the meantime, what we have is medications. And so, I tend to be an advocate of at least discussing it with your patient. That was a long answer. I always have a lot of thoughts on that. Yes. Yes. Yes, you're right. Yes, yes, yes. Yes, yes. In the original study, not in the randomized control trial. Yes, in the, yeah. It's a different kind of TMS. Yeah. Oh, versus, ECT is actually pretty low risk. It's just underutilized. So I don't know the answer to that. I don't know how safe. The thing about ECT, so the issue is that you wouldn't want somebody awake and to be seizing because then you get, so the issue that with ECT is that the uterus is relaxed and so you don't get any decrease in blood flow. So I don't know. I don't think you could do that without medications. So just for the residents, so it's part of the normal psychology of pregnancy to regress a little bit. That's why people when they either love or hate their OB. So when you're just in normal pregnancy, you just, in your psychology, you regress a little bit, and not in a negative way. And it's a very healthy thing. And so you are more likely to build relationships with your doctors more quickly. And so, again, it could be one of the reasons that we're seeing a high placebo rate. And we do know that. And, you know, we try to do everything we can. The ADHD data, I just don't think it's strong enough yet. Again, I would go back to the idea that you can overdose an animal on anything, and a pregnant animal on anything, and without a human placenta, you just don't really know what the outcome's going to be. And since ADHD is such a genetically driven disease, I think it's hard to know. And I'm not saying that these medications can't have issues. What I'm saying is you have to weigh that against the issues of depression and anxiety. So I think it's very important that you look at the right control group. The control group is not your non-depressed, healthy, well-supported, married female. This is a whole different person. And is that person and that baby more at risk from being treated or not treated? And that's what you have to figure out. If you use yourself as the control group or your friends as the control group, you're not being fair to that woman. And I think that's really the thing that you have to keep in mind. But I think you have to be careful about the animal data. And we work very closely with our vet school, and they do all the mouse and rat studies. But I'm a little bit suspicious because it's not really borne out very well. Yeah. Uh-huh. Yes. Yes. So, and I think that's important, again, for the students and residents. This is never something you would want to do unless you know how to document really well. And the number one reason to be sued as a psychiatrist is really abandonment. So you don't, but it's all about the relationship. I have a whole nother talk where I talk about people that I won't treat during pregnancy. Times when I've turned people away, which is very rare because I'll pretty much do anything. But if you have a patient that's hostile and you cannot build a trusting relationship with, don't get involved. Or a patient that is like hypomanic and won't follow what you say, do not get involved. So I think that's a really important point. The relationship has to, if you're going to do this kind of work, it is higher risk. And the relationship has to be very strong. You have to feel confident. And you just have to be able to say to people, I can't promise you a perfect pregnancy. But what I know from all of our lives, we know that you fall in love with that kid no matter what, right? I mean, kid could have half a, brain, you fall in love with the kid no matter what. And I think before the kid comes along, people don't really get that. But once the kid comes along, you fall in love no matter what. And the OBs are still much more likely to be sued than we are.
Well, I know this has been a wonderful lecture, and there's lots and lots of people who want to ask questions. I didn't know until I heard her say it that she's interested in coming back. And I think that would be wonderful to have her back and continue this. But my responsibility is to make sure she doesn't miss her flight. So I apologize that we can't continue the questions. However, again, Dr. Kim's very responsive and helpful. I think if you have questions, she'd probably be willing to respond by email. And right. And I'm definitely going to follow up on her kind offer to return. And I mentioned the studies that we're doing. She has already agreed to be our consultant for these studies. So we'll be having a working relationship ongoing. So, Dr. Kim, that was an excellent lecture, as I knew it would be, and we appreciate it very much.